Our last key point for our week 3 unit is diabetes. This lecture will give you an overview of diabetes as well as some of the treatments that we might look at from a dietary standpoint. As a quick overview, let's keep in mind that carbohydrate is digested, it's absorbed into the cardiovascular system or the blood vessels, and then if it's not in the glucose form already, it's converted to blood glucose. A normal BG, or blood glucose is what BG stands for, would be anywhere from 70 to 110 milligrams per deciliter. You'll find that when you go to different lab locations that sometimes those numbers can vary slightly, but in general 70 to 110 is considered a normal blood glucose level. We don't want it too low below that or too high. If it gets too low, we need to remember glucose is the form of energy that feeds especially the brain and the central nervous system. So when we don't have enough glucose available, the consequences when the blood sugar goes too far below 70 is that we may go into a coma. So again, glucose is the preferred fuel for the body. Blood glucose regulation is very tight because of this. It's controlled by two hormones called insulin and glucagon, which I reviewed in our previous lecture on carbohydrate digestion. Insulin works to lower blood glucose levels after a meal. So when the pancreas senses that the blood glucose level is getting high, it sends out insulin, and insulin acts to pull glucose into the cell to provide energy to that cell. And as it does that, it brings the blood glucose levels down. Now, when the blood glucose levels get too low, let's say we haven't eaten for a long period of time, the pancreas releases glucagon, and glucagon works to stimulate the liver to break down its glycogen stores, and release glucose into the bloodstream, which then increases the blood glucose levels. We consider the condition of hyperglycemia to be defined as any blood glucose level greater than 110 milligrams per deciliter. Some symptoms a person might have if your blood glucose level is too high would be increased urination, extreme thirst, ongoing hunger, wounds that won't heal, or blurred vision. Hypoglycemia, which is when the blood glucose level is too low, has certain symptoms that go along with it as well. Being shaky, hungry, sweaty. Some of you may feel this to a certain extent, and it might not be that your blood sugar level's below 70, but maybe you're getting to that lower end, somewhere around 70 to 75. Things that you might feel are lightheadedness, kind of that extra hungry feeling that you might get, and that slightly off mental feeling when you haven't eaten for a long period of time. There's two types of diabetes. Diabetes type 1 used to be termed insulin-dependent diabetes mellitus. That is old terminology, although a lot of doctors are still using it. For short, they might call it IDDM. This is type 1 diabetes. We consider it an autoimmune disease. The body's immune system in this situation attacks the beta cells of the pancreas. So the pancreas is no longer capable of making insulin. So in type 1 diabetes, the pancreas does not produce insulin at all. Usually this is considered a juvenile onset type of diabetes, although there are certain uncommon situations where it can come on later in life. Anyone with type 1 diabetes has to take insulin injections. What they're doing is they're essentially acting as their own pancreas when they inject the insulin into their body. But it's required with type 1 diabetes. There's no other way around treating that condition. About 5 to 10% of people with diabetes have this type, which accounts for about 700,000 people in the United States. Type 2 diabetes, which again used to be termed non-insulin dependent diabetes mellitus, or for short NIDDM. Now some doctors are still using that terminology, but the current terminology should be that this type of diabetes is called type 2 diabetes. In this situation, a person's cells become resistant to the effectiveness of the insulin that they produce. So what happens is we talked about how insulin works as a gatekeeper at the cell site. And so think of the insulin as the guy with the key that can open the door to the cell and allow the glucose that is in the bloodstream to get into the cell and out of the blood. If that insulin is not effective, and they think in type 2 diabetes, and many times this comes on when people are obese or overweight, that somehow that distorts either at the cell site or the insulin shape, so that those two, the cell and the insulin, aren't able to communicate together as well. So not all of the time can the insulin actually open the door to the cell to let the glucose in. Sometimes it's effective and sometimes not, which then causes the blood sugars to raise up higher than they should be. This is usually an adult onset, although we're seeing an incredible increase in the number of children who are being diagnosed with type 2 diabetes. There is a strong genetic link, although not as strong as with type 1. The number one treatment for type 2 diabetes is if a person is diagnosed with it and they are overweight, is we would start there and encourage them to work on losing some weight. In addition, exercise would be paramount as a treatment. Exercise works in a couple of different manners to help manage blood sugar. So it would help somebody incorporate that activity into their lifestyle if they don't already have it, and then teach them strategies with their diet. Sometimes type 2 diabetes requires oral medicine, and sometimes it requires insulin, although it does not require any medication at all at times. 90 to 95% of people with diabetes have type 2. So what are the symptoms of undiagnosed diabetes? I have the diagnostic criteria listed there. We're going to skip over that, and you can give that some time to look over. I'll just define that OGTT stands for oral glucose tolerance test. And those are the three different ways that a physician might diagnose diabetes, either through a fasting blood level, a random blood level, or oral glucose tolerance test. Increased urination would be one of the key symptoms. What's happening is the kidneys are removing excess glucose that was in the bloodstream. The body's trying to find ways to get rid of that extra sugar that was not able to get into the cells because the insulin isn't working properly. So the kidneys can remove some of it through increased urination. But with that also goes water. So many times the person ends up dehydrated after that increased urination, which then precipitates increased feeling of thirst. There's increased hunger. That stems from the fact that the cells are not perceiving that they're getting energy because that glucose is not able to get into the cell to be utilized. So it triggers the brain to signal hunger. Complication of diabetes. So what's the downside? Atherosclerosis. We see greater than 80% of people with diabetes die from cardiovascular disease. So a very marked increase in the risk for atherosclerosis and stroke. Kidney disease. They're 17 times more likely to deal with kidney disease if they have diabetes. Blindness, neuropathy, poor wound healing, and again, a lot of this has to do with that sugar that's running around in the blood and it's trying to go somewhere. It's trying to get out of the blood. So what it ends up doing is it binds to proteins on the tissues. That gets in the way of wound healing. That also gets in the way of good vision. The blurred vision that a lot of people with diabetes complain of comes from the fact that those sugars in the eye area, the eye is trying to dilute that out, so fluid flows into then the eye area, which distorts the lens of the eye and therefore distorts their vision. Amputation is a complication of diabetes, and diabetes may decrease life expectancy by 1/3 if it's not controlled. And that's the key point there, is not controlled. It's not the ticket or the license to an early death. It's just that if the lifestyle factors are not worked on and blood sugars are not controlled, then it may result in that. Who's at higher risk? Anyone who's obese, has a family history of diabetes, or certain ethnicities. They do see higher rates of diabetes, such as African American, Asians, Hispanics, and Native Americans. Anyone who has a history of gestational diabetes, which is having diabetes while they're pregnant only, or that has delivered a baby that's greater than 9 pounds. A larger baby can indicate the fact that maybe there was some undetected diabetes going on during a pregnancy, which caused the baby to get larger than usual. It doesn't mean that every baby that's over 9 pounds came from a pregnancy which was impacted by diabetes, but it may reflect that. Gestational diabetes is one form of diabetes, and it occurs in the latter part of pregnancy. Up to 10% of pregnant women do contend with this. Screening at 24 to 28 weeks is now a routine process. And what they would do is have you take a little bit of orange soda, which is a certain dose of carbohydrate, and they check your blood sugar before you take it, 1 hour after, and then 2 hours after, to see how your body's able to tolerate that sugar dose. And based on what the results are, they would assess whether you had gestational diabetes or not. The increased hormones that take place when someone is pregnant may be what blocks the insulin's activity in the mother and causes her to be more at a state or a condition which brings on the diabetes. It often disappears after the baby is delivered, but those ladies are then at higher risk for diabetes at another point in their life, type 2 diabetes. Large babies are many times one of the complications of gestational diabetes. What happens is that extra sugar running around in mom's blood then is transferred to baby, and of course sugar provides energy, which promotes growth, and then the baby ends up storing it as additional fat on their body, which makes the baby larger. The risk for this is the baby gets too large, then sometimes it triggers an early delivery of the baby. We wouldn't want that to happen, because even if the baby's larger, not all of the lungs and finer details of development have completed themselves, even if the baby becomes large. The other concern would be that if the baby is delivered and the doctor is not aware of the gestational diabetes, that baby, while they were inside the mom, was producing insulin from their own body in reaction to the higher levels of sugar that were in mom's blood from the diabetes. And as soon as that placenta or the umbilical cord is cut, the baby's no longer getting that ongoing dose of sugar from mom. So what happens is the baby's insulin continues to work, yet not getting any sugar input from mom. So there's a tendency for the baby go into a low blood sugar. So it's important for doctors to be aware of that before the baby is delivered, so they can be ready with a dose of D50 to give to the baby to bring that sugar up. Other complications may be jaundice or respiratory distress syndrome. Again, this is because the baby might be developed too large, so there's poor lung development, and that causes the lungs to be weak and put the baby possibly into respiratory distress. Complications for mom that might arise with gestational diabetes is something called preeclampsia. Preeclampsia is designated with a set of 3 different symptoms: hypertension, which is high blood pressure, protein in the urine, and generalized fluid retention. So this isn't the standard fluid, a little bit of puffy ankles that all pregnant moms contend with. This would be the type of puffiness that comes up into the hands and into the face and neck, where there's marked fluid retention. Preeclampsia, the concern with that again is that it might cause mom to have early contractions in delivery of the baby. Urinary tract infections are more common in someone with gestational diabetes as well. Some treatments. A diabetes treatment is something that we first take an assessment of the patient and where they're at, what type of diabetes do they have, what is our goal altogether. Carbohydrate counting, my first bullet point, is the most advanced approach to treating diabetes. What it involves is learning how to count the carbohydrates in foods, and this can be learned by using the exchange system that we discussed in Chapter 2. It also is outlined in the appendix of your textbook. A person learns to count the grams of carbohydrate in all of their food, and then at the same time they also learn how much insulin do they need for every gram of carbohydrate that they take in for their diet. And they learn how to treat and give dosages of insulin based on exactly what's on their plate. So for instance, they might learn that they need 5 units of insulin for every 15 grams of carbohydrate. So then when they have a 30-gram snack, 30-gram carbohydrate snack, they would give themselves 10 units of insulin just prior to eating that snack. That's an example of carbohydrate counting. It's very advanced. It's for the very motivated person. Typically we use it with our type 1 younger folks. This wouldn't be a treatment we would give to maybe a 75-year-old who's got mild diabetes, type 2 diabetes, and not that motivated to make changes. The approach with somebody like that might be on the lower end, where we talk about just healthy food choices, small, frequent, balanced meals, helping them know how to spread those carbohydrates across the day without at any one given time having a large dose of carbohydrate. I kind of liken it sometimes to the idea that if someone came up to me and asked me to lift 100 pounds at one given time, I might have difficulty doing that. But if they told me, hey Teresa, you can lift 10 pounds at 10 separate times to equal 100 pounds, I probably could do that with no problem. It might be the same way for our bodies when we're taking in carbohydrate. If we can spread that carbohydrate across the day in smaller doses, it's much more likely that our body's going to have the ability to manage that carbohydrate intake without having a blood sugar that runs out of control. So that is one approach, and a much more practical approach for someone who is less likely to institute major changes into their lifestyle. When I worked in a diabetes treatment center, outpatient clinic, we used to love the idea that, we really consider exercise as serious treatment and can be a replacement for taking diabetes pills. So we would consider exercise like our pill. And if we could get someone to incorporate exercise or activity daily, and sometimes twice a day, sometimes that would be all they needed to get them off of medication, but still controlling their blood sugar. What does exercise do? Number one, it can increase the cell's sensitivity to insulin, so making the insulin that they already have in their body much more effective at controlling blood sugar. Number two, it can help them with weight loss and managing their weight overall. Number three, immediately after a meal, and I don't have this on the slide, but it can help bring down blood sugars immediately after a meal, just with utilizing the energy that glucose provides. I bring up hypoglycemia one more time because someone with diabetes that is taking medication, this is a risk when they take oral medicines or insulin to treat their diabetes. They wouldn't want to get into a situation where their blood sugar kind of bottoms out, as we might say. Again, the symptoms are written down there: hunger, dizziness, sweating, irritability. The trick with this is that anyone who takes medication for their diabetes or insulin should carry some sort of carbohydrate snack with them at all times. And they should carry this and treat it as if it's medicine. So sometimes we do say, get some glucose tablets. at the pharmacy. They're over the counter, and they're nothing more than really just a instant form of glucose. But if they buy glucose tablets, they're more likely to treat that like medicine and not eat it at some other time just as a general snack. That's important because if they do find themselves out and they don't have anyone else with them, but they feel these symptoms of low blood sugar, it's important for them to treat right away. And the way you treat something like that, we call it the rule of 15, that you take 15 grams of carbohydrate, you wait 15 minutes, you assess for symptoms, and if the symptoms continue, then you treat with another 15 grams of carbohydrate. If you're taking glucose tablets, that means taking 3 tablets. They're typically 5 grams of carbohydrate each. But this could be as simple as a half a cup of orange juice as well. The type of snack you would not want to have at this time would be something that contains fat or a chocolate-based snack. Yes, those have carbohydrate and sugar in it, but fat slows the absorption of sugar into the bloodstream. At a time that somebody's falling into a low blood sugar as an effect of their medicine, what they want to do is take pure form of sugar in some way. So we consider juice or even sugar packets to be an effective way to treat hypoglycemic symptoms.